Now we have an amazing panel for you to wrap up our content here today. Moderating our panel, where's Tyler? I gestured this way and realized he wasn't here. Tyler Simpson, our health tech lead at A.Team. And joining him, we have Jessie Beegle, Aniq Rahman, Morris Panner, and Katie is joining us again. So everyone, please take the stage. Please come up. I'm going to hand this very precious mic to Tyler.
Awesome. How's it going? My name is Tyler Simpson. I've been here at A.Team for the last 14 months. I presently lead our health tech function here. I'm working with founders, technical leaders, innovation leaders from early stage startups up through large health systems to drive their innovation goals in a more efficient manner. I'm really excited to be able to provide a space where people across the continuum of care can come together and drive conversations that are meaningful to you. Couldn't be more excited about our esteemed panelists and the dedication of time that you've presented towards this panel and being able to provide your insights and points of view into a topic that is overwhelming for so many. So I'd like to start off by just having a brief introduction, who you are, how you're leveraging AI, and taking it from there.
Should I start?
Absolutely.
Sure. Well, my name is Morris Panner, and I'm president of a company called Intelerad. And Intelerad does sort of, if you want to think about it, the ability to visualize images that come off of scanners. So that's how radiologists kind of do their work. And as you can imagine, for us, AI is something that does two big things. One is it starts to bump up into the area of diagnostics, and we can talk a little bit about that. But it also does a lot in terms of workflow. So it makes it easier for radiologists to spend their time doing things that are related to patients rather than doing things that are related to preparing studies. And it sounds mundane, but it has a massive impact on productivity.
You guys already heard from me, but for those of you that I put to sleep, my name is Katie Whigham, and I'm from HCA, and I work on a innovation team within HCA that we are expected to kind of pressure test where generative AI or emerging technologies can assist in the healthcare space. So a little bit more of a global approach. So.
Hi, everyone. My name is Aniq Rahman. I'm the founder and CEO of a company called Fabric. We've been around for about 3 years, and we use AI in a bunch of different applications. We're helping with patient navigation, with triage, helping patients navigate the complexity of health systems for everything from billing questions, clinical questions, scheduling. And then we also have an asynchronous telemedicine platform that helps really streamline workflow for physicians and APPs to help patients get care faster. We've treated about 5 million patients on the platform.
Amazing. Hi, everyone. Jessie Beegle. I have been in health tech my entire career. So I was at GE, started the healthcare team at AWS when no one knew what cloud computing was. I heard the mainframe comment. Haven't been around as long, but that was fun to introduce and explain what cloud was to health systems and pharma. I was at DeepMind with Google, helped start Walgreens Health, and then most recently was at a health system. So I feel like I've done the full tour of duty outside of an insurance company. So, there's hope for me yet. I don't know if that's a good thing or a bad thing. But my career has been really around evangelizing new technology. What does it mean to the enterprise, as well as how to get tech teams to speak the same language so we can really spur innovation and adoption. And I loved your presentation from Mount Sinai. It was a great framework. I think more people in health systems seem to have folks like you. So it was awesome to see.
Amazing. Thank you so much for that. So we've talked a lot tonight about adoption, being able to adopt actual AI tools and what that means. Harvard Business Review in the fall put out an article about what things can we change to increase adoption across AI, regardless of industry. And one of the points that they made there was changing the narrative about the purpose of AI. What is it actually being used to do? Can you talk a little bit more about what you're using AI to do in the present versus what you see being possible more long-term?
I can start in radiology because I think it's kind of, it pretty much corresponds to what you just said. So initially when AI came out, the articles, there was a famous thinker who said, if you are going to medical school and you're going to radiology, you will be unemployed in 5 years. The AI will replace you. There's no point. And I think what we have seen is a change in attitudes where now radiologists are saying, could you please get AI because it can enhance my workflow. It can make me a better doctor. It's not going to replace me. And that's been a pretty dramatic shift in the narrative.
Yeah, I would actually echo that. We have our platform, we're seeing that across the 5 million patients we've treated on the platform, asynchronously, the average physician or APP work time is about 89 seconds. And so we can do the full triage, evaluation, diagnosis, and treatment in a minute and a half, which if you juxtapose that to a typical 15-minute appointment block, it's really a force multiplier where the provider can see 10 patients in that time rather than just one. And so it's really a workflow tool. It also helps with increasing adherence to clinical protocols, improves patient safety, helps the provider consider things that they wouldn't necessarily always consider. And I thought, Rachel, your framework was fantastic. There's so many things that, I think AI can help enable, but, patient safety is always paramount. So having the provider in the loop, and I think that's where the regulatory world is still obviously evolving. But I think in most cases, you can build AI products in an unregulated way by having providers in the loop.
Yeah, and I'll just build upon one key word that you said there, which is it's a tool. A lot of times, especially like in traditional enterprises, people think, oh, you're going to sprinkle some fairy dust of AI and fix everything. And that would be wonderful, but it is a tool. And so the way that I really talk to enterprises about new technology, especially AI in the current state, is what are you solving for? If you're a hospital, what are your top 3 priorities? A lot of times, and I think a lot of the folks that come from hospitals, or just if you've been to the doctor recently, there's such a workforce shortage, right? So that's a key problem. What generative AI is really good at is making people more efficient in certain tasks. So if you start to start at 30,000 foot and then come on down, that's where you start to think about different applications and usage of this tool to supercharge someone, whether that be a nurse, whether that be someone who's doing scheduling, whether that be a physician. So he or she can be more efficient with the things that are a little bit mundane that he or she probably doesn't want to be doing anyway, but knows they need to do. So they can spend more of their quality time with the patient doing something that is required by a human, where you have empathy and things like that a machine can never replicate. And so I think that regardless, for anyone who's in here, when you talk about AI, really talk about it as a tool that's in the tool chest of that worker, and how can that really help benefit he or she in their day job.
Since we're all answering, I totally echo what Jessie just said. That's the main I think right now, that AI has presented an opportunity is just presenting it definitely as a tool or as an enhancement to the workflow that they're already doing today. Definitely, you have to combat that culture of you're going to replace me, because I'm doing an operational situation. And then I think we're slightly scratching in the surface of, a clinician gain, but still really with that air of a human in the loop, just raising awareness or something that is a little bit more difficult to see. But yeah.
Absolutely. No, I'm sorry.
I was going to say, I was listening to a podcast the other day, and it just kind of reminded me of that. Think about before the internet existed, right? Everyone uses the internet now. It didn't necessarily replace what you do, but it makes your job a lot easier to find where you're going if you're traveling in a new city. And so that's a way to kind of really think about how can AI enhance what it is, the task at hand. Because I don't want to pull out a paper map. I don't know about you guys, but love to do that in radiology, right? Get through some of the stuff.
You didn't MapQuest your way here, or
printed
No.
directions.
I was about to make a Bing joke, but I guess Bing has AI in it now, so maybe I can't.
Yikes! Yeah,
That's the old joke that we used to be able to make.
No, I love the fairy dust analogy that you use, because AI is a tool. It's not a magic pill. It's not going to solve all your problems. Very easy to talk about the advantages that AI presents. What are some of the challenges that you're seeing that AI brings to the table that we need to be aware of?
So from sort of an entrepreneur's point of view, I think the toughest thing about AI right now, and Rachel, your presentation was fantastic in terms of the framework, is how to really bring that ROI message and be able to instantiate it into the workflow. Hospital workflow, any physician workflow is really, really, really hard to change. And unless you're able to fit into it and drive value in it, it's hard to commercialize. So you could have a great idea, you could have great tech, but that will, I think, slow you down. So that's not necessarily a criticism of AI, but it's kind of how an entrepreneur has to think about some of the barriers to adoption.
Yeah, I'll just go around it's not a magic button. And I think often to operations, when they aren't necessarily individuals that have to try to understand the technology and what it takes to get there. They're sold on the magic button, and that's their expectation walking into it. And it's very difficult to slow walk it from there and have them be along for the journey with it. And so I think it's really about the presenting it in a tangible fashion, but also realistic, especially when it comes to healthcare. And so, I think that's the part where us as an internal group within the four walls really has to navigate when vendors are out there selling a magic button, and then they are an invested party, and then they realize how difficult it is working with our data and so on and so forth. And it just becomes very unrealistic. And so I think it's good to be honest of the road ahead, but I think naturally people are coming in selling magic. So
we only did that once.
Yeah. Hey, it's okay. I mean, I think it's a part of it, and you got to get them. There's a little bit of a bait and switch there, but you got to get them to bite first, and start trusting it in some fashion. But operationalizing is a whole different ballgame. So.
Yeah, I mean, there's a tremendous healthcare worker shortage that's happening in the United States and projected to grow to 3.2 million workers by 2026, according to one study I was reading the other day. And so, you kind of juxtapose that to also just the, like HCA, I think, bought a nursing school, right, mm-hmm. to address some of the
Smart.
nursing shortage.
Right. They can't leave, right?
Yeah. Right. And HCA is one of the more labor efficient health systems, right? I think labor is like less than 50% of your total operating costs, which is very different than a lot of other health systems, right? So I think, we kind of think about it as like, it's very hard to replace a physician or a nurse, but a lot of the work that a nurse does could be reclassified as administrative work. And so we can kind of like save a few minutes here, a few minutes there. That adds up in totality to maybe save hours every day. And then I think, thinking about also just the longitudinal patient journey, can we follow up with all of these patients in a more consistent way? Can we make sure that they're adhering to their protocols? Can we escalate that to a human at the right time to intervene? And so I think as you mentioned, integrating that natively into the workflow, that means it has to integrate with clinical systems of record like the EHR, it has to integrate with the CRM, it has to integrate with all these things that are not necessarily technically, you can't just tell OpenAI to integrate into Epic. Exactly, right.
If it was that easy, right?
And it's a regulated space, and you have to be really thoughtful about how you integrate with, patient information and do it in a compliant way. And so, our approach is really kind of thinking about this sort of in a platform setting, because, also, Lifepoint, HCA, Mount Sinai, you have made these foundational clinical investments, but then you also have hundreds of point solutions that plug into this, not to mention your own homegrown technology stack. And so it also has to really be deployable across the whole system. It's really hard to sort of be a point solution that just lives in one department on one use case.
Yeah. And when I was at Lifepoint, I used to say that we were the New York City of health IT. We had every piece of health IT ever created. I think we had Meditech, MedHost, Epic, Cerner, Athena, and some other. I think we had one of the HCA EHRs as well. So when you think about bringing in new technology, and that's what the reality of healthcare looks like, it'd be great if everyone was Stanford and Mayo and all on one instance of a single EHR. But that's something to keep in mind too when you or maybe you're pitching a large enterprise about your wonderful solution, which is there's no such thing as like a free pilot. Like there is a lot, and Katie can speak to this about on the tech side of the integrations and the people time that is required to get anything up and running. So that's one thing. But on the enterprise side, I'll say this. Really giving folks a baseline to go off of, right? So if you're a hospital COO, you're a hospital CFO, CEO, you're very smart at running hospitals and managing costs. technology might not be your every day. And so they know enough to ask questions, but I think giving a really strong baseline so you can get to that question that's keeping you from a yes. And so I've had lots of conversations around, I was asked, what is the ROI of cloud computing, just period. And well, anything that you say to that makes you sound like a jerk, because the response is, what are you using it for, right? But you can't say that. And so when you think about AI as well, I think just keep that in the back of your mind when you're talking to these folks. I think folks want to use new technology. They want to alleviate the pressures on their workforce. They want to be more profitable. They want to drive business results. They want to help their patients. But helping them lead them to water, I think, is something that we as a community that understand this technology, it's really on us to help educate. And so I think the folks in this room are doing that, but it's just a reminder to be very mindful of that, because that is a big issue that does keep from that last mile of adoption, which is like bringing folks along that come from a more traditional mindset, so they can be involved, feel like they're part of it, to really spur more adoption faster.
And maybe just to underscore what Jessie and Aniq said, we literally do time motion studies where we look at seconds saved, and on cost, we'll look at pennies saved. And so it's tight. I mean, these margins are extraordinarily tight.
Awesome. So as you can imagine, I spend a lot of time talking about this subject with different people, and a recurring theme that I always tend to hear about is the use of clinicians in the training of AI models or in development of new products. As you're looking to bring new products or models to market, who is involved in that process, and when would a clinician be involved in the development of those?
So from our point of view, I think one of the most powerful trends we've seen, and I'm looking at some people I met here tonight, is the real crossover of physicians who are kind of multi-threat individuals. They're doing entrepreneurship, they're doing clinical work. And so I think you're starting to see clinicians embedded in almost every stage of a company. Certainly in our case, it's very difficult to really go anywhere without a clinician, because you need that adoption and you need that sponsorship. But I think you're now starting to see more and more clinicians gravitate to that part of the world. And I think that's a great development for everybody.
They're there at the beginning and the forefront. I mean, HCA, even though I work at the corporate office, is often hiring clinicians within that to impact the change. And I mean, we apply in our innovation space, we apply user-centered design. And so at the forefront, we're talking to the SMEs, or, that could be clinicians, it could be whatever that is. And we actually leverage product design a lot to cultivate and pulling out of them what their desire actually is. And I do feel like if used appropriately, taking that group of individuals that are named, all the way through, they actually can be your champions at the end. And so it's important to get their buy-in and make them feel part of the change from the beginning. But also, in order to become a SME and be more effective, because we're building a lot of custom applications, I mean, they have to be a part of it from the beginning. Otherwise, change is really difficult.
Yeah, I mean, I echo that. I think with the health systems that we're working with about 70 health systems now, and some of our initial design partners were really generous and gracious in sort of hosting us to bring our engineering, design, product teams to the front lines to really just shadow nurses, shadow patient interactions, sit in the waiting rooms. Jessie was talking about the pre-internet era, right? You walk into almost any of the 6,000 ERs in the US, and it almost feels like the internet doesn't exist, right? Patients are just kind of sitting there in a waiting room.
Where the signal's really bad.
Right, exactly. Yeah, that too. The Wi-Fi doesn't work either. And so I think we're very much kind of thinking about it from a product design perspective. The second thing is, on the clinical side, all of our clinical protocols are written by a team of nurses, informaticists, physicians, and then we have review from a team of about 18 chief medical officers and medical directors from across the country that are part of our customer base. And so that team, the Clinical Quality Advisory Council, they meet regularly every month or two to review and update to the latest and greatest in evidence-based medicine. And so it's, I think this is one of those places where generative AI can help you with a rough draft, but at the end of the day, you need validation, consensus, and you need to take again, it's patient health at the center of it, also taking a more conservative approach with human review.
Yeah, and as you can hear from Aniq, like if I was sitting here talking to him when I was at Lifepoint, those are the types of questions that I would ask, because it's like, oh, you're not just throwing technology at a problem in the healthcare space. You're having it reviewed by clinicians, by nurses. You have this council to help continue to advise you as you iterate. And I think that that's a really important thing too, is having folks along the way from the beginning, as Katie mentioned, because then you're going to have buy-in. You're going to have something that is designed to actually solve a problem. One of the really sad things in healthcare is most traditional enterprises have bought these very large monolithic systems. And because they've spent so much time, because they've spent so much energy training folks, you just start to tack on additional applications on top of these large systems. And having spent time at Google, having spent time at Amazon, or if anyone's been at Apple, you pull out one of those products, it just works. And the reason it just works is what Katie said. It is user-centered design. It is. I remember I brought Palantir into Lifepoint, and we had some engineers following around one of our OR directors, and she, said, "Hey, I'd love to see XYZ." And literally the next day, the engineer, who was like 22 in a hoodie, and she was like, "Jessie, who did you send to me?" But I was like, "It's fine." He was like, "Oh, I built what we talked about yesterday afternoon." And she's like, "We talked about that at like 4:30. When did you build that?" He's like, "Oh, I didn't sleep, but I built it. Like, what do you think?" And she goes, "The buttons, even the color that I said in like the hallway." And it was all about, he was listening to the user and then said, "Okay, let me go back and build something specific to the problem and then the different functionality that you wanted to see." And I remember the OR director called me and said, I've never seen this. Like, this is not what I expect when I come into work every day. But when I go home and I pick up my iPhone, or, I'm using my Alexa at my house, I see that in all the other facets of my life. So I think this idea as well of bringing user-centered design to healthcare, it's very difficult to do because there has been so much investment. But I think when we're thinking about net new things, how do we really stress that as well as wonderful technology?
Amazing. So want to leave some time for audience interaction. Would love to open it up to Q&A. There's specific questions you'd love to ask our panelists. Opening the floor up for those questions.
About as far as it stretches. Let's come right there.
Hi, everybody. I think all the presentations are really great today, and had a question about patient experience and the opportunity for you all. What you're building can really help patients and help advocate for them. How are you taking into consideration the social determinants of health into your AI solutions?
I mean, in radiology, it is probably one of the most complicated and discussed questions, because it's very difficult for, it's a very complicated question. And in some ways it starts at the beginning where you're trying to build models, and you want to make sure you've built a model that is representative of the different populations that you're addressing. You want to make sure that model stays on point and works. And then also you want to make sure that populations can get access to it. So there's controversial programs where sometimes people can pay out of pocket for enhanced AI screening. Should that be something that should be made available to everybody? There are these ethical questions that are involved in the building of AI, as well as the maintenance of it, and then ultimately the deployment of it. So there are, at a high-end radiology medical conference, the number of panels that are dedicated to wrestling with these issues is significant. And I don't think people have answers, but it's very much, I think, top of mind.
We worked in a year and a half just specifically focusing on patient experience. And I will say I still show up to the doctor and I have to fill out papers. So I don't really have much positive thing to say here, because we built a product. It's just not out there. So yeah, I think it's an ongoing tackle is really, but and one very difficult to keep up with. So
Yeah, and I think I think patient experience done in isolation is maybe like a barrier to adoption. I think it has to thread the needle on improving provider and clinician experience and also helping with operational throughput and efficiency. And so one place where we do this, just in the emergency department, for example, is allowing patients while they're sitting in the waiting room to go through their nurse intake on their phone and just answering yes, no, yes, no. And that all localizes to the patient's device settings and language. So we've translated those questionnaires into Spanish, into French, into Haitian Creole, into other languages that sort of match, improve access, reduce the interpreter services that are necessary sometimes to get those answers. And then, the beauty of asking those questions on a patient's phone is that you can ask a lot more questions than a nurse might have time to ask, and you can make some of those optional. So you can, and patients also sometimes find the phone to be a digital safe space. So just imagine like a teenager going to the ER with their parents. They may not want to verbally talk about their sexual health in front of their parents, or we've seen patients that show up to the ER. Our first week we deployed it, we had a 22-year-old male that showed up and said that he was there with chest pain and clammy hands. It turned out the real reason he was there is because he was depressed and suicidal. And so he told that to the app, didn't tell a single human. And so that they were able to escalate care team, get him immediate medical attention. So I think like there's all these benefits to technology, but at the same time, it has to also not change any workflow for the nurses, so that patients that don't have a smartphone or don't know how to use the technology or not comfortable with it, will revert back to the status quo.
Yeah, no, I think that's those are all really great points. I think one of the other things to think about is participation in like data sets, right? So I'm blanking on exactly what the algorithm was, but there was an algorithm, I think it was around some sort of breast cancer detection. And there was this ethical question around, well, we trained on basically white women from North America. Should we release this algorithm if it does not work for women of color? Right? It works for this segment. And, you could go both ways on that. Like, should we use it to support these women? But then now you're leaving this other very large cohort out. And I don't think the intent is by any means to do that. But that's one of the real ethical questions that you start to see when you get into a lot of these algorithms. And it's based off of the data that's available. And so there are a lot of efforts ongoing right now. So I think it's definitely very much a work in progress. But, to Aniq's point as well, when you think about smartphones, like they're very much everywhere, but not everyone has one, or they're the older population that maybe not as tech savvy, who cannot open my chart to save their life. My mother is one of them. So I am tech support when she has to open my chart. And so I think that those are things that we're all very conscious of when we're continuing to build, but it's still the early days. But I think when you do talk to folks in the space, patient engagement, patient satisfaction, supporting folks where they are, which incorporates like their social determinants, because that is really where your health is determined. It's not necessarily the 2 or 3 times you go to the doctor, are all very important to really drive change. So I think it's still more to come.
In that study that you referenced, it's sort of interesting because it spawned Yeah. And it spawned real concern about how populations were identified. And actually, an emerging area in AI is being able to monitor the AI itself and be able to understand what goes into model creation. And it's kind of it's illustrative of how AI kind of is, I think, a pretty big growth area, because all these areas need to be addressed and expanded. And there are a lot of emerging companies that are rushing in to fill that space.
Any other questions from the audience? Yeah.
Maybe you could share, if you have some experience, about dealing with the FDA or regulatory bodies, particularly when it comes to justifying and qualifying algorithms, when it comes to actually making diagnosis. From personal experience, we've been working with seizure detection, and it's quite a challenge to get them on board, particularly when it comes to non-deterministic models or learning models. So do you think that FDA and related bodies are sort of advancing and are coming closer to sort of catching up with the field, or are they still holding it back?
I think it just because radiology gets bombarded with this because they really do diagnostic models. And it's very hard for the FDA right now because there are legitimate questions about drift. There's, they worry about bias. They worry about what they are approving. And it has proven to be difficult. I actually kind of think the FDA path is an interesting one. But one of the things, if you can instantiate your AI algorithms into where a physician is ultimately making the decision and using it as an aid and kind of slow roll the FDA approval process, I think that's helpful because I also think the FDA gating process is less important than making sure you have something the physicians can use in their workflow. So if you can use something as a diagnostic aid as opposed to the definitive diagnosis, it can, I think, really accelerate the business, because going through FDA approval is hard, and I have some empathy for them because of some of the questions that were raised here tonight. It's not easy to answer.
Yeah, definitely human in the loop is the stronger way to go. I know HCA is definitely working for advocacy though too at that government level for allowing more generative AI to occur. But we kind of go through that just of maintaining it being more of a workflow tool, but maintaining human in the loop. There's no decision being made by the technology. So
I think if you have an unregulated pathway, go that way. Like the FDA's guidance on this has been, just all over the map and not clear. Even people at the FDA have very differing opinions on it. And I think it's like somewhat incongruent with building an early stage company. I don't know what stage your company's at, but like you're going to end up spending $1 million on legal bills from lawyers that don't necessarily agree. So yeah, we'll talk more afterwards.
Yeah, I concur with everything they said. I think FDA is trying, but it is a uphill battle for sure. I will say this: I was very pleasantly surprised. Senator Blackburn is the senior senator in Tennessee, and she just got on the Senate Finance Committee, and we had a session in Nashville where we brought a bunch of like innovative companies. We brought a bunch of health system leaders, and the whole goal for her was to talk about, she goes, I'm now on this committee. I actually want to be, she didn't say the health tech czar, but I really want to be a champion of this change because there is so much of an economic like push for, the state of Tennessee around healthcare. And she sees that as a real opportunity to like kind of cement her brand on Senate Finance. When you think about funding, it's set by Senate Finance. And so you do start to see folks in government that really do want to learn. But again, we have to like help like equip them with information and what's going on so they can continue to educate others on the committees. But I think that that's the slow change we're going to need to see. So it was very refreshing to hear that there was interest, but still a long way.
Awesome. Once again, thank you so much to our panelists for dedicating the time to come share their perspective. Love to turn the mic back over to the one and only Joe, the Laser Show Laser.